Thank you for coming out today for our Lunch and Learn. Today's topic will be hip fractures, something that we see a lot of, unfortunately, in our practice. Typically, they don't walk into the office with hip fracture, but at the hospital, we get consulted to come see them and take care of them. Hip fractures are very common as we get less young. Part of the reason for that is we get osteoporosis, which is thinning of the bone. We can figure that out with a bone density test. With the bone density test, the results either come back osteoporosis, which is significant bone weakness or bone thinning. Osteopenia is kind of moderate bone loss, and a normal bone is what we hopefully all have now and will continue to have. The ways we can try to help our bone density to avoid a hip fracture: weight-bearing exercise, appropriate nutrition. Theoretically, calcium and vitamin D supplements could be considered as we get less young. So a lot of postmenopausal women end up on them. It's kind of controversial on how much they help and whether it's truly good for you or bad for you, and what dose to use, do you skip a day, things like that. So that's a conversation between you and your medical doctor. Other prescription medications to help bone loss or to reverse bone loss, things like Beniva, Actonel, Fosamax. There are also injectable medications that we can use to try to strengthen our bones. The downside is they're all expensive and they all have side effects. So it's also, once again, kind of controversial on how much we should promote those. Also, sometimes you go on what's called a drug holiday, which sounds fun, but it's really basically, a drug holiday is after being on a medication for a number of years, they have you stop that medication, which hopefully then gets your bone metabolism back to more normal to try to prevent stress fractures that can occur if you stay on things like Fosamax for years at a time. Other things that might help prevent hip fractures, if you have poor balance, things like Tai Chi or other exercise programs. Also, if you have poor eyesight, getting glasses and things like that. There's a lot of reasons elderly people fall, and if their bones aren't strong enough, they break their hip. There are different types of hip fractures. We have a model today, pelvic bone and a femur. So basically, our hip joint is the articulation between the top of the femur, the femoral head, and the acetabulum, which is part of the hip socket. So when we move our hip around, that's what's going on. When we use the word hip fracture, we're typically talking about fractures at the top of the femur rather than a pelvic fracture. Although it's the other side of the hip joint, we typically, if they have a hip fracture, it's typically a pubic rami fracture or some type of acetabular fracture, and so we use terminology that's different than a hip fracture. So different types of hip fractures. So the anatomy: the femoral head, femoral neck, which can also be called subcapital, the greater trochanter, which is at the top, and then the lesser trochanter. Basically, you can get a fracture anywhere through that bone or any other bone for that matter. The most common types that we deal with are typically femoral neck, inner troch, and then subtrochanteric or sometimes shaft. For the femoral neck, which is a very common pattern with falling, it can either displace and come apart, or it can stay lined up relatively well. If it stays lined up relatively well, the treatment is different. So if we have a patient that we suspect a femoral neck fracture, but the x-ray is inconclusive, we typically do an MRI to prove whether it's broken or not. Because if it is broken and it's very subtle or non-displaced, we can simply put 3 screws up into the femoral head to stabilize it so they don't need hip replacement. And that's considered a good thing if that's going to work. Or if it's minimally displaced, we'll sometimes do that. Or if, say, you're 55 and you have a traumatic fracture even younger, there's a chance the doctor might try to reduce it and put some screws in there to get to heal so you can preserve your femoral head. If you're, say, 65, 70, elderly, like a lot of hip fractures occur, then we're typically doing a replacement procedure. And there are different types of replacement procedures, of course. 20, 30 years ago, if you broke your hip, a standard prosthesis was an Austin Moore. It was a one-piece design. Basically, the femoral head fit right onto the piece, almost no femoral neck, and they came in different sizes. So you try to figure out which size was the best. The broken part would be removed, and you'd simply replace it with a device like this. For people that are not real active, it did pretty good, but for active people, it didn't do very well. The sizing wasn't quite right, and the dislocation rate was probably higher because of the design. Nowadays, it's a more formal femoral stem that can either be cemented or press fit. There are different neck lengths, there's different head sizes, so we have a lot more variability. With a A unipolar design, basically whatever size the femoral head is, we try to match that with a one-piece ball design to put up inside the pelvic bone. That can either be cemented in place or press fit in place. Some people love to press fit, which is fine. The downside to press fitting though, because the bone isn't necessarily real strong to begin with because of osteoporosis, you have a higher chance of creating a fracture during surgery or potentially getting a fracture after surgery than if you cement this down. So a lot of people believe in cementing femoral stems for hip fractures, but certainly not everyone. The other design, besides a unipolar or one-piece design, is a bipolar, where you have a smaller ball inside of this that rotates around. So it's basically two ways of articulating that may reduce the dislocation rate, although that's uncertain. If you're a younger person, say 55 or 60, and you break your hip, you're probably more likely to get a hip replacement, a total hip. You really don't necessarily need a total hip right then because typically your acetabulum is fine, but the concern is with time, if you just have the ball wearing on your cartilage and it doesn't fit exactly right, theoretically the cartilage is going to wear out, and then you're basically having an arthritic type hip where you've already had part of it replaced, and then you're getting another surgery. So try to avoid the second surgery. You can just go ahead and do total hip replacement at the same time, or putting the socket in the pelvis, which can go in with or without screws, typically a piece of plastic, and then some type of a ball, whether it be ceramic or metal, once again either cemented or press fit stem. So that's the options for the femoral neck fracture. With the femoral neck fracture, if we do the 3 screws, we typically limit your weight bearing for a certain period of time to try to get the bone to heal. With some type of a prosthesis or replacement, we're typically letting you weight bear as tolerated right away. Now going on to further down the bone, intertrochanteric fractures that occur in this area are treated differently. The main reason for that is blood supply and healing issues. The further down into the intertroch or below, blood flow is better than the femoral neck, so it's more likely to heal if we retain that broken part. So the devices to fix that, either a sliding hip screw type device, and the reason it's called a sliding hip screw, as you can guess, because the screw can slide within the device, and it's designed to do that. So if the fracture is in the intertrochanteric area, this goes on the side of the bone, that actually goes up inside the bone, and then the screw is up inside the bone as well, stabilizing a break through this area. And it can compress. And the reason they designed this is because one-piece designs would often break, so they realized if the screw could compress and let the fracture stabilize, it was much less likely to have an implant failure, so the sliding hip screw is designed. A stronger implant, and some people would argue a better implant, for the same fracture pattern has a device going inside the bone. This would be an intramedullary device. Some other names you might have heard are gamma nail. This would be a short gamma nail. Other companies, TFN is another name, trochanteric femoral nail. Depending upon the company, they have their own name for their own product. Basically, this is also designed to slide, although it's captured so it won't slide here, but it's designed to slide, once again, to compress for the same reason. Here's a newer design, similar device, a short gamma nail, goes inside the bone, and I don't have the exact screw that fits that, but once again, it allows it to slide this way. Often there's another screw stabilizing it here, and there are longer designs that can go all the way down. For somebody very osteoporotic or an unstable fracture pattern, you can put the longer nail in with or without screws to stabilize it down here. And this design is also used for the next class of fractures called subtrochanteric fractures. So you can break it down below the trochanters, which is a kind of a often more difficult fracture pattern to treat, but with this intramedullary device, compared to the plates and screws we used to use, is a better device, it's stronger. So once again, that's down inside the bone. You have a screw up here, and then that stabilizes the fracture here, or even lower down. I had mentioned the blood thinners, Fosamax, those types of things. If you stay on those for a long time, it can put additional, it doesn't make the bone stress, but it changes bone turnover, which makes you more prone to a stress fracture down at the top of the femur, so we have to be aware of that. So people coming in complaining with thigh pain that have been on Beniva or Fosamax for a long time, we check for that. So that is a quick overview of hip fractures. What questions do we have? Please ask a lot, because that went really fast. Or we'll have to order more food. Or dessert, maybe.
when do you decide to use a DHS or the slide hip screw versus gamma?
That's a good question. So he's saying, why would a surgeon decide whether we do this design or an intramedullary design? It's typically based more probably on your training and experience than on the fracture pattern. For a very stable fracture pattern, this is a great device. But it's a bigger incision, and it's, in my opinion, a little bit more cumbersome to get in than the nail. But certainly for an unstable fracture pattern, if there are lesser trochanteric regions broken off or something further down, certainly this is a stronger device. This can be used for basically any intertroch fracture pattern, where for a stable fracture pattern, I think this is probably fine, but either can be used. This is kind of the older device, but still very good. The nails are a little bit newer device.
I missed part of it. The intertroch
Yeah,
fractures.
we noticed that.
The intertroch fractures are typically from osteoporosis.
That's a great question. I think femoral neck or intertroch can either be from osteoporosis.
But would you agree that a lot of times if somebody has an intertroch, it's osteoporotic bone?
Yes, I would agree with that.
Okay.
Right? I would also think that a lot of times the femoral neck probably has some osteoporosis.
Yes.
Yes.
So my question
I'm
is.
not sure if I'm being harassed or if there's a yeah, I like it. Keep going. We're losing up time.
So when would you use a short versus a long nail?
That's a fine question. So he's asking basically when would we use this nail versus this nail to stabilize the fracture. So for a certainly for a subtrochanteric fracture, I'm going with a long nail every time. For a stable intertroch, or if their lesser troch is just minimally off, or if there's not a lot of comminution or osteoporosis, I often use the short gamma nail. And simply because for this nail, they have what's called an outrigger device to put that screw at the bottom, there's a screw that goes through here. So there's a device that connects to very easily target for that screw. For the longer nail, because there's so much lever arm, it's hard to get a device that targets that, so it's a little bit more cumbersome to get that screw in. But it's basically based on how much osteoporosis in the fracture pattern. For almost all of my intertrochs, I do a short nail. For all my subtrochs, I do a long nail. There are some people.
I'm the exact opposite.
Really?
I don't
long nail for everybody?
For everybody.
Everybody gets a long nail.
Because I consider it a pathologic fracture. That's where I was getting. Because I
Okay.
think osteoporotic bone is pathologic.
Okay.
Technically pathologic, so
Okay.
I use long nails on everybody.
I know with the original design for the original gamma nail, there was a fair high incidence the way the nail was designed. I'm not sure if it was the size of the nail or how it was put in. There was a fair high incidence of sub fractures occurring after the surgery. So you get a stress riser here and they break below it. With the newer design, in my experience, I haven't seen that. So I use a lot of these. There are other nail systems that have this design, but they put their screw hole higher so that you could use a long nail and still get the targeting device to use it. In a lot of, they would call it the practice of medicine or the art of medicine, because truly, you can treat many different things different ways. Typically the outcome's good either way, but certainly, if I had one or two subtroch fractures happen afterwards, then I'd be real quick to switch to this forever. But I just haven't seen it.
That's where I'm at. I've had several short fail.
Have you? Okay.
Yeah, so that's
And below the implant, with the older gamma or the newer gamma, or which?
It was with the Intertan.
Intertan. Yeah, that's another brand. Yeah. And it might be because once again the original gamma nail had a similar problem, and I think they changed the design of it for that reason, and I haven't seen it since then. So it might be a design thing, or it might just be the osteoporotic bone.
Well, Synthes has a new one that's out. It's like a medium length nail.
Okay. So not short, not long, but
Correct,
medium.
but
Yes. Okay.
So you don't measure it, and it has an outrigger, so you kind of get to eliminate the stress riser distally, but you put in your nail or your screw, your locking screw, like up much higher.
Up higher. Yes. Okay.
So like I think you're talking about that. Yes. I've not had any experience with that, but it sounds like a pretty novel idea.
Yes. We're always trying, the companies are always trying to improve things, come out with a better design, make the surgery easier on the patient. Yes.
Is that Austin Moore, is that cemented in?
I think some people would press fit these, and some people would cement them. It's been so long since I've done one, I can't remember how we do these. Did you do these in your practice? Never done a salami.
I've never even seen
We
one.
call it a salami. Speed of light, Austin Moore, endoprosthesis. So that was the nickname for the surgery.
This is the first time I've seen one.
Really?
Never,
You're allowed
never
to touch
seen
it.
it. Okay. Read about it.
You've read about it. Now you've seen one. Interestingly, I recently went to a conference about a year ago in Philadelphia, and the guy that's doing all the new joints and using the robot said when he got to Philadelphia, like 15 years before that, they were still putting those in routinely.
Wow.
Yeah, and that was like, he literally said like 15 or 18 years ago, they were still using that routinely. So, but I haven't put one in 20 years. When I trained at Akron General, we put those in on occasion. But huge difference in design. This meets the anatomy, plus there's a lot of variation you can do where this is just, there's literally like a size 1 through 5, and you just kind of guessed what size was closest. And I think it could be either cement or CrossFit. Excellent questions.
Thank
You
you.
should go in medical school. Any other questions we have? Yes.
So if they have a hip fracture because of the osteoarthritis, loss of bone,
Osteoporosis. Osteoarthritis is arthritis. Osteoporosis is a bone density.
loss of bone,
Yes.
putting the implant into the bone, does that not compromise the loss of bone anymore? Does it make that bone stable
That's
and
a
okay,
great.
or?
That's a great question. That's a great question. The most of our strength of our bone comes from the cortex, the outer part of the bone. And we do have to drill a hole to get it in there, or obviously if we're doing the device on the side, we're also drilling small holes through the bone, through the cortex. But when it goes inside the bone, it's in the medullary canal. So there is a natural canal inside our long bones that part of how we make our new blood cells, and it is through that bone marrow. So when we're putting this in, it's in the bone marrow, and we're not necessarily trying to take away the cortical bone, which is the strong bone. So that's how it makes up. So when you push this in, the goo comes out. If you watch Seinfeld, they talked about getting to see inside the bone one time. Yeah, but it's the stuff inside the bone marrow. But it doesn't weaken the bone by putting the rod in. Now, part of putting this in is you can put a reamer, which is basically like a drill down inside the bone to ream the bone out to get a certain size nail in. And if you're too aggressive with your reaming, theoretically you could weaken the cortex. But then hopefully, if the rod goes beyond the weakened part, it doesn't really matter anymore. Give her a raise. Any other questions? Excellent. Questions, Amy? Come up with anything? No? Thank you for your time. I'm sorry that I stopped 10 minutes short. I'm sure you're all upset by that. Next time I'll do it in 2 languages next time.